Hello, and welcome to today's event, a virtual roundtable looking at the current and future state of interoperability. I'm Carol Flagg of Answers Meeting Network. Thanks for joining us today. This event is sponsored by Consensus Cloud Solutions, whose suite of products unlocks essential data and delivers it securely when, where, and how you need it. Learn more at the company at consensus.com. Before we begin, just a couple things. First, you can adjust your viewing settings individually, as well as your audio settings from your own device. Also, we'll get a copy of the recording out to you within 48 hours. And now I'd like to introduce today's moderator and our panelist. No stranger to our virtual events, Jim Tate has over 20 years of experience in healthcare delivery, information technology, and compliance. Jim is the founder of EMR Advocate, a consultancy firm working with health IT vendors on certified EHR technology, including design, functionality, and data interoperability. Jim's eHealth background includes both clinical and technology, and he presents frequently at national HIT conferences, is an active blogger and webinar presenter. He is also the host of the Tate Chronicles on our own Healthcare Now radio station. And now I'd like to introduce our panelists. Lesley Berkeyheiser is the senior site reviewer at the Electronic Healthcare Network Accreditation Commission, better known as EHNAC, and a principal at the Clayton Group. She has over 25 years of healthcare experience, specializing in healthcare regulations with a focus in security and privacy. She also is an active member and participates on the work group for Electronic Data Interchange Strategic National Implementation Process. That's a lot, shortly known as WEDI-SNP, and also frequently presents public presentations as well. So glad to have Lesley on board. Joining Lesley is John Nebergall, who is the Chief Operating Officer of Consensus Cloud Solutions, where he oversees the commercial operations, sales, marketing, e-commerce, and customer care. Prior to joining Consensus, he led the J2 Cloud Fax business and architected its transformation into an emerging enterprise-grade supplier of interoperability solutions for healthcare. With over 20 years of executive experience in healthcare, John brings a deep knowledge of electronic health records and health information exchange technology to Consensus. Prior to entering the healthcare IT industry, he worked as a senior VP at Experian. He also served as an adjunct professor of clinical informatics at the University of Illinois, Chicago, and has written many position papers, white papers, and journal articles on healthcare interoperability. And finally, winding out our panel is Paul L. Wilder, who is the Executive Director of CommonWell Health Alliance. With more than 2 decades of experience in health IT, Paul has held various roles focusing on imaging, clinical informatics, and of course, interoperability. Prior to joining CommonWell, Paul was Vice President of Strategy and Business Development for Philips Interoperability Solutions. He also spent 10 years with one of the largest regional HIE networks in the world, the New York eHealth Collaborative, serving as its CIO, VP of Product Management, and Program Director for the NYEC's Regional Extension Center. Prior to joining NYEC, Paul spent more than a decade in healthcare with a focus on information technologies at McKesson, Fujifilm Medical Systems, and GE Healthcare. And now sit back as I turn the discussion over to our moderator, Jim Tate.
Carol, thanks so much for that introduction to our roundtable participants today. I'm really looking forward to this because we're going to have an opportunity to hear from 3 people who really are deep in the interoperability domain, but they have varying perspectives. So I'm looking forward to hearing from those different avenues. As we know, the factors driving interoperability really go across the healthcare spectrum, and they impact payers and providers, and of course, patients. I want to start at the very highest level. I always like to ask people these questions. And so let me just say this to our panelists. I'd like to have each one of them weigh in, is what is interoperability and why does it matter? Paul, if you don't mind, I'll throw that tennis ball to you first. What is interoperability? Great. Why should we care about it?
Well, I don't have a dictionary, so I'll make up my own definition.
That's what I want.
Yeah, that's what I figured. So interoperability, you can think of it as really the movement or connection of data between either disparate systems or disparate entities and their systems. And I think there's you can look at both. There's stuff inside of IDNs and inside of hospitals, inside of provider practices to connect their systems together, which is probably what we were more focused on 2 decades ago, and interface engines and the like. And now we're really at the edge of those institutions connecting to each other, either system to system or through integration APIs and the like. And it's to the benefit of every patient. I mean, any of us who's been experiencing healthcare and seen the change in the amount of data that's available to provider at the point of care sees the difference, like the ability to get labs and previous procedures and diagnosis directly into the application without having to go through and extract it from you. That's changing pretty rapidly. And so we're just trying to make that rapid change a little more focused, get the data better, get the full data set and make it something you can rely upon, as opposed to being kind of extra data you get in addition to the H&P, in addition to the things you do. So excited to be here, and I can't wait to hear everybody else's answer.
Yeah. Lesley, what about you? What's interoperability to you?
Well, first, to me as a patient, it's about having access to that data that I need. Even though I'm not, I'm very healthy right now, I have multiple places where my data resides, and I really need access to it, and it needs to be obviously secure and available as I need it. But speaking from an accrediting body perspective, it's making sure that as this data moves around in an interoperable way, that it does so in a way that we also know we can trust each stakeholder. And I'll speak about that more as we go on.
Okay.
Is that me, or is that?
Well, I figured the head of CMS was trying to reach someone. So I guess we can call him back afterwards.
Okay.
What about you, John? What's this interoperability business all about?
Well, I kind of keep things very simple. It really is about the free flow and secure exchange of important information between the people who need to send it and the people who need to have it. It's all in my mind about 3 things. Well executed interoperability adds important information to somebody's knowledge base that they need to be able to perform something. And it does it with speed, and it does it with accuracy. So really what you're trying to do is get that just right, just in time information to the point of care, be able to do it in a seamless way, and be able to do it in a way that doesn't wind up creating hardships or difficulties for either the sender or the receiver.
In the drive towards interoperability, there certainly have been best practices learned, lessons learned. There probably are also been some missteps, hopefully, that we've taken advantage of. But let's talk first about, in the drive towards interoperability, what some of the challenges are that have been addressed. Now, I know such things as standards and code sets. Lesley, I know you're deep into that kind of stuff. All that had to be worked out to even figure out the type of discrete data and how that could all be normalized. So where are we in that, in the issue of, meeting that challenge of the standards and code sets?
Well, I believe it's obviously still an ongoing process. We're building on top of the initial bases that we've had in healthcare now for 20 and 30 years. I do believe that with respect to standards, we continue to make sure that they're dynamic and they evolve as our technology evolves. But still really starting to talk about interoperability now and moving into the details, I think it's really important at the highest level to think about, we still have an environment where across the industry, everybody's not meeting the same level or bar, even from basic privacy and security. And now what's really happening in interoperability is we're introducing new actors, or I hate to use that term, I'm starting already to pull definitions from some of our new rules, but
Sure.
We've got new participants, if you will, that may or may not be subject to the things that we all commonly think everybody has to do, like basic HIPAA security. We have technical app developers, we have others that may be handling this data in interoperability, and they're not necessarily meeting the same standard level to privacy and security, et cetera. And that's all separate from what data gets moved around and how we move it around. So I think from that perspective, it's important to note this is still our United States healthcare still has a lot of disparate systems. We still have a lot of with people at different levels. And we need the standards and we need the best practices that are being driven by so many of our wonderful efforts that even just, some of those on the call today and thinking about our ONC, our Office of National Coordinator and FAST initiatives that are now moving over from the accelerator. I mean, we've got to keep driving. So the standards are there. We need to keep raising the bar, and especially from an accreditation perspective, making sure that all the stakeholders, whether they are subject to HIPAA as business associates or they're covered entities or they're not subject to HIPAA at all, everybody needs to meet a certain level to keep that data confidential, keep its integrity, and keep it available as needed.
Yeah. Paul, I don't know if you or John want to weigh in on that too, about some of the challenges that have already been addressed so far. We'll get to the ones that need to be addressed, but things that 10 years ago we knew we would have to jump over the bar with, and we've accomplished so far.
I think the primary thing we've gotten through pretty successfully is getting provider to provider exchange to work, which is why I say kind of define interoperability as their systems connecting. But I can't answer that without also previewing what's not quite working yet, which is I think we have a P2P problem. Anytime the two Ps are the same, interop is actually not that hard. And the data stuff and the standards, that's all fine. And we should always need to work on that. The data should always get better. We should always have better standards for underlying data, et cetera. But the real trick was the trust frameworks that got the data to be trusted to move across, right? And then what happened is you had enough adoption that you can now look and say, oh, wait, this data isn't very good, let's fix it. Or this data is great, don't touch that thing. But when we cross Ps, we still have a challenge. And by the Ps I mean is provider is fine. Patient to patient, I can send my data anybody I want, any way I want. Provider to patient, you have a problem. Payer to provider, provider to payer. Once you cross these Ps, and for the fun of it, add public health. Let's put a fourth P in there. Anytime you cross them, things get dicier because the trust framework and the mutual destruction or mutual benefit changes in each one of those things. And we still have a fair amount of work when we start doing that kind of a cross-P collaboration.
Yeah, I think you're right. And I think it even expands past that into social work, home health work, post-acute work. I mean, those are all places where you're crossing those, I guess what you would call the well-established idea that you have in your head that this is all about provider to provider communication. The actual ecosystem and the set of stakeholders needed in order to provide care and that would fall under HIPAA are certainly a very large expanded set of players, and we have to be cognizant of each of their ability to send and receive securely and understand what they're sending and receiving.
For gosh, I want to say for at least 2 decades, there was a large movement towards what were originally called RIOs, Regional Health Information Organizations, and then HIEs, Health Information Exchanges. And correct me if I'm wrong, that always seemed to me like a spoken wheel type thing, as opposed to provider to provider. Is that kind of going away somewhat, and we're moving towards more of a decentralized, or are we moving towards decentralized exchange?
Well, I think what we're moving towards is a network of networks. There are reasons that would make sense for you to have data repositories. And I kind of equate things back to where I started my career in credit reporting, of all places, and you have very large repositories of important information that is easily exchanged and shared between an ecosystem of people who need that information. The information has to be secure. And then I moved from there to HIEs with Orion Health.
Yep.
And, the similarity between those two was not lost on me. And what wound up happening in the financial services industry is that you wind up with a network of networks. You have a number of these different reporting agencies that have large pools of data that people tap into. And you have people who share information directly to each other when the information needs to be something other than summarized, or somebody is looking for something very specific and doesn't want to go through a huge volume of information to find that something specific. So I think the two coexist. I think that you wind up in a spot where you have trusted networks connected to trusted networks, and the exchange of information happening within those realms.
Well, right. You mentioned those repository castles, more or less, of data. They can be used for population health management, for clinical research. There's a real need to continue that. I asked y'all what your definition of interoperability was. Let me give you what mine is, or what I would consider the holy grail. That no matter what provider I go see, they're looking at the same record. I would like that to happen. I'm in a town in Chapel Hill, North Carolina, where the hospital and the providers are all connected, and there's one portal, and they're all looking at my record. I like that a lot, but I know as soon as I drive 50 miles away, that's not going to be happening unless I maintain my own record. So that's my definition. I'm not sure, and it's probably spotty all over the country. Let me mention a couple of things about some of the challenges I think have been addressed. We've got these standards for discrete data. We've got regulations, and we'll go into, well, we can talk about now the regulation around information blocking. So that is the government stepping in and saying you cannot build a wall around patient data. Now, I guess we're in the early stages of that. I guess that was part of the Cures Act. Is that correct? The deadline around information blocking?
Yeah. 20%.
And so was that really necessary? I know there are proprietary reasons that maybe some institutions or vendors wouldn't want to share data, but was it an intentional thing, or just the way that networks and applications and systems are set up that it was difficult to share? So is this going to help the information blocking provisions of the Cures Act?
I asked that exact same question, Jim. I grew up thinking about HIPAA and how we're supposed to be sharing data for purposes of treatment, payment, and operations. Over and over, it's why not? But there were some organizations that either misunderstood or didn't do it, or needed to be basically penalized if they do not share correctly. And that's why we've got our info blocking rule. It's saying, hey, you can't purposely put these barriers up. I find what's very interesting right now is it seems like we have a real tug and pull. I was working with an HIE earlier today, and we were talking about how the info blocking rule is making it sure that you share the data. And then this HIE is saying, I've got these tech app developers knocking on my door saying, hey, I need the data. But the HIE wants to make sure they can trust them, and they're not sure how much they can do appropriately and not be violating. That's what the concern is. There's this fine line between I need to be able to trust, I need to share, I have to follow the rules, the patient access rules, et cetera. I know I'm going beyond info blocking right now, but I have to do my due diligence and make sure I can trust the other party as well. So I think to some degree, having all these rules at the same time, and many of them having to do with access, whether it's, info blocking and sharing because you can't be putting up a barrier, or it's the patient access rule and making it available because you have to. I think having them all at the same time in one way is wonderful, and in another way is very confusing for organizations, and especially that provider that has to know if they're supposed to deliver and share or not. So I'm kind of all over on this one. I think one of the best things we could do is to have continued information from authority to authority, looking at the various areas the rules cross over, like info blocking and how that's saying you must share, and plain old HIPAA, and that's saying that you are permitted or required to share, and then patient access rule about how you're supposed to share. We're talking about sharing, but we're doing it in 3 different rules that come from 3 different authorities, or, crossover an authority. So an area that I think as an implementer or those who help the industry implement, we can do more.
I work with a number of EHR developers, and when we first discussed the fact that O&C certification for EHRs required publicly open and published APIs, access to patient data, they didn't believe it. They said, no, that has never happened. We're never going to do that. But if a patient gives permission to some third-party application out there, essentially with probably a user ID and a password, that patient's data can be accessed by a third party. And that was kind of shocking, I think, to a lot of developers who never thought that wall would come tumbling down, or certainly there was a culture towards you don't let any unknown outsider with permission. I know there's a certain level of trust, but it's really up to the patient. And it's when most patients go to the hospital or they see a provider, they sign a bunch of documents. And one of the documents is it's okay to share my data with everybody who's going to be taking care of me, including the payers. And so those payers out there, my gosh, they have more data than anybody probably. From it doesn't matter what your EHR is, your insurance company, whether it's Medicare or Blue Cross Blue Shield or somebody else, they've got all that data because everybody wants to get paid at the end of the day. So we can't forget them. They certainly are part of this. A couple of things that I want to bring up about challenges that have been met. The macro MIPS program, which as far as Medicare, rewards to a certain degree or penalizes reimbursement based on promoting interoperability scores. So it's somewhat simplified now. It's going to get more complex, but reimbursement is based on the ability to meet some standard of interoperability. So that's certainly the government putting out some things there. And then, of course, certification requiring those open APIs. And, that was a big step forward. So let's talk about those APIs a little bit. I can remember when the early, maybe in the 1970s, when fax machines first came in. And to me, that was the first giant step of interoperability. I was working at a practice. Patients would come to us. We were a specialist practice. Patients didn't know why they were there. We didn't know why they were there. You call the referring physician and they'd fax over stuff. We thought, gosh, that's magical. But there's still been movement at that. I mean, from that, to me, that was the first step of interoperability, where those fax documents and fax files now can actually be turned into structured data. So there are a lot of different ways that this data can come into a system that's not purely discrete to begin with. I don't know if you want to weigh in on that a little bit, John. I know you've been doing a lot of work in that area.
Yeah, we have been, and it's interesting that you mentioned the 70s. Actually, for the record, fax was initially introduced and actually something that people used in 1843.
You're kidding?
I'm serious. The horrible truth about fax is that it was a protocol for sending electronic information that existed far, far before computers. And it had the unfortunate reality that a whole billion-dollar industry popped up that spit out paper to be able to show you what that fax said.
Yeah.
What we've seen is that, you know, the ability for somebody to communicate effectively in the language of healthcare today, it is very different than it was even 5 or 10 years ago. And what we're really thinking about is unleashing the power of the computer to do the translation for us. And you know, I was recently in Panama, of all places, and I needed to have a conversation with my Uber driver. I don't speak Spanish. And I actually used the translate function on my iPhone. I spoke English to it. It spoke Spanish to the driver. He spoke Spanish to it, and it spoke English back to me. We had a conversation. And I think that when you think of protocols and standards, when you look back 5 or 10 years, you had to write those to the capability of what the machine could do. And what we're seeing now with the application of AI and machine learning, that you can actually put that pressure on the machine. So, you know, a doc that has access only to a fax machine can send something that is rendered on the other end as a perfectly formed HL7 message. Or a large healthcare organization can send a FHIR message, but since it's sending it to a home health agency that only has a fax machine, it can be rendered as that fax. People get what they want the way they need it through the application of what the technology can do today. So the conforming of standards was always the interesting problem that I thought we wanted to solve collectively. If two physicians get together and have a conversation, they can talk through cases and information and perfectly understand each other. For some reason, when you put that into a patient record, those two doctors can't understand each other at all. And the need for us to say, okay, you all have to talk the same language starts to be able to go into the background as the computing power of systems today can actually solve for that and have things start out as one kind of communication and be delivered as a different kind of communication based on the preferences of the sender and the receiver.
I see. We've talked some about the challenges of interoperability that have been met. Let's talk a little bit about the challenges that are yet to be met, or the potential for things to be lost with interoperability. And I'll tell you one that I'm concerned about is I don't want to see clinical notes disappear. There's a generation of providers who would get a dictation, a transcription, and they skip down to the summary. They read that paragraph, and they know what the treatment plan is and what the medications are. And so if they just have discrete data that's been reconciled into the EHR, I kind of wonder if the story, and by the story, I mean some information that is not structured, is not discrete, gets lost. And it's not just for reasons of, I think we need to preserve it. It's just for care, you need the patient's story. And that is often more than just data. So I'd like to hear what challenges you think are yet to be met and what you think about the potential loss of, or am I worrying about something I don't need to worry about, loss of those clinical notes?
Yeah, I think John actually hinted at this already, talking about the doctors communicating with each other do a fairly good job very quickly, right? It's a 5-second handshake to figure out where to start from, versus with data, it's hard to know where to begin to ask the questions that matter. And what we're seeing now is it's almost like a religious warfare here. There's one camp that's all about the discrete data elements. There's one camp that's all about the discharge summaries and the clinical exam notes.
Yes.
I think they're rapidly realizing that you need both, and it shouldn't be a war, it should be a truce in the center of what works. And the reality is there are certain data elements that there's no reason they shouldn't be exchanged very easily. You know, the things that are easily coded, they should be coded, and
Yep.
they should have good provenance data so we know where it came from, so we're not duplicating things and we don't have to go through. I mean, quite frankly, John, it's great that AI can do this stuff, but it shouldn't be that hard to know that this aspirin came from X place and it really was supposed to be 50 milligrams or whatever it was. Like, it shouldn't be that difficult to figure out if that's the same aspirin now sent through an HIE going through another EHR being spit back. And the reason why I see 4 of them is because everybody absorbed the data and regurgitated it back to the point where it looks like the person's taking 2,000 pounds of aspirin every day. We should be able to fix that. And that's really better tagging and provenance. We should get better at that. But the exam notes, I think most doctors want to maintain that, especially when it comes from changing environments. So going from inpatient, outpatient, and back, because that's where the story kind of, why were you in the hospital? What did they do? And what they learned that I didn't know, right? Because that's where, you know, if it was only data, robots would be able to do this, and it'd be telehealth to a robot on the other side. And the reality is there's a fair amount of art in medicine. It's not pure science. And so we will need those things to say, this is why I did what I did, because I saw X, and you don't see this in the data. What is the sequence of things? At 10 o'clock, we saw this. At 10:30, we saw that. And that's why we went this direction. And you should be aware of that going in the future, because that's how this person responds to that drug or this treatment, not how the general population does on averages. And that's kind of the important part. It's that specific medicine to how I am treated and how I should be treated in the future as well, so we don't make the same mistakes over and over again. So I think we're getting to a convergence where people realize you need both, and they both have a very important place in interoperability.
And they absolutely do. I think that when you're thinking about which problem is being solved and you approach it very holistically, you have a perspective around how the interaction and subsequent ability to interpret that interaction leads to ultimately the delivery of care. And I think that when you try and solve the entire set of problems associated with how do I have patient-centered care and ensure that no matter where that patient is, frankly, in the world, that they can have the kind of care that has the benefit of that patient's full history and the provider's understanding of what that full history means. I mean, that's a very a large problem to solve, and certainly one that is going to take, I think, a lot more time and energy than we're going to see in the next year or two. I think if we can narrow down the problem of purely getting the information from point A to point B in a way that is reliable, secure, trusted, and both ends of that conversation can understand what it is that's been communicated, I think we may be a bit closer to that.
Agreed.
If I might add as well, I'm just going to take a little bit, I'm going to add on to Paul, and then I want to also talk about ongoing risk assessment and how it relates to not losing data, whether we're in a HIPAA world or an interoperability world. First, though, Paul, I think I totally agree with you with the two camps. I was just speaking not long ago with a clinician, emergency department clinician, and she said, the CCD is really pretty. It's very nice. I don't have time for everything in it. I just want to know the hemoglobin of this patient the last 4 times it was taken, no matter where that was over the last 30 days. Yeah. And so she said, that's why I like FHIR. I know we're all starting to say the FHIR word. John said it first. I was waiting to see who would bring it up first. So I just wanted to leave that comment as well. We definitely need the opportunity to get the discrete data too immediately. Back to just risk assessment for a minute, because so much is about implementation. And just when we were all looking at initial compliance with HIPAA and then with high tech, I like to think from that perspective, we now look at it from an interoperability perspective. And Jim, I'm thinking more of your question about losing information. It's one of the things that as an accrediting organization at the Electronic Health Network Accreditation Commission, we see often is that everybody knows they have to do their NIST this or their HIPAA risk assessment or whatever, but they're not putting together, it's all about the data that's being handled and starting with that data first. Whether it's PHI or it's EHI, whatever you want to call it, it's the subject for which you're putting your safeguards and controls in place. And so we all now collectively across the industry in stepping up and having this data interoperable available to us, we have to add our plain old-fashioned risk analysis that we used to do and make sure that we trend forward and look at whatever it happens to be, whether we're talking about using FHIR APIs and moving the data that way, or what levels of authentication and authorization we're going to be using. All those things have to start with the data, how we're handling it, whether we create it, receive it, maintain it, transmit, and just bring it to the interoperability world. I think that's something we're learning. One more quick thing, if you don't mind, Jim. I'm trying not to pay attention to the chatting, but I saw somebody say, FHIR APIs are insecure. And I just want to add what I think our HL7 friends have been saying is add on to that. It's the implementation of the FHIR APIs and the levels of authorization and authentication that may or may not be secure that we need to talk about. So that might turn your whole next question. Sorry, Jim.
No, that's good. And
Good point, Lesley.
yeah, we probably went 30 minutes before somebody dropped the firebomb. And I appreciate that because the ability and the functionality to get very specific data as opposed to all the patient's data. As you mentioned, I want their hemoglobin A1Cs for the last 30 days and just get that information. That's powerful. I don't know if that's being utilized much. The timeline, I guess the deadline for that for certified technology is the end of December 2022, I believe, if that's correct, that certification requirement. And so for providers to get used to doing that, I guess that's a cultural shift. Certainly government regulations are pushing that. I don't know, will it be a couple of years before the power of FHIR really enters the marketplace? I mean, the technology is there, but when will it be used on a wide basis? I guess that's still a question mark, isn't it?
I mean, we're seeing just from industry ins and outs, like on the patient access side, it's pretty out there, right? Every vendor knows the certification requirement, knows that it's right. You asked a question earlier about info blocking, and interesting what I've seen a lot of activity on the vendor side on info blocking. And partially it's like partial claims by patients and other vendors that they just never thought of what might be perceived as blocking. So they're not doing it intentionally. They just didn't realize that, for example, a really bad UI to release data is a form of info blocking, right? If you make it nearly impossible, you need to put in your roadmap to not make it impossible anymore, right? Can you just make it a little easier? But the one concern I have with the certification, it is very patient focused. The patient focus is a lot of it on the US CDI, which is a lot of the discrete data with a little bit of clinical exam notes, but not a lot. I actually think access by patients, and Lesley mentioned this before as well, is probably the most important thing, even though I say interoperability is a lot of that provider exchange. I am the most likely to give any credence to the quality of the data about me and whether it's being duplicated and doesn't make sense, because I have to maintain my existence for a lot longer than my provider individual at any point in my life does. So, we probably need to get better at getting the access. And that information blocking thing, it's good in theory, but the practice is it's missing a fair amount of details of how to do it securely. So the exceptions are leading to, intelligent versions of blocking. And that's bad, right? It's like, oh, I can not answer because I don't know you, or I don't know how the app verified you are who you are. How do I trust that they really know who you are? Oh, I can use username and password. That's great. but where they get it from, are you secure? There's a whole bunch of things that pop up that people can still say no on. So we can just a little bit of work on the security side of what's a minimum bar, maybe even a safe harbor of if you do X minimum, you're kind of protected from being in court arguing whether you did it right or not, right? So that you don't have to get through that and have so many tort requests trying to figure out what that bar is. It would be nice if there's a little bit more distinct, okay, if I do this, I'm safe enough, right? I have an argument and I don't have to worry about all the stuff that I worry about as a CIO, as a CISO, as a CEO, which is a big deal. The malpractice was the big, we don't talk about malpractice as much anymore. Now it's about worrying about where the data is going and whether that's going to be the next thing that sinks an organization completely by accident.
One topic I want to touch on is the fact that we're coming up on 2 years of a global viral pandemic. Maybe a month or so ago, we thought we were starting to see light at the end of the tunnel, but we don't know how far away that light really is. And so how did COVID-19 identify gaps in our interoperability? What was it that we were fell short on that we wish we had more data? Now, of course, patients couldn't come in and see providers. We know that. So new types of technology, remote patient management and telehealth, telemedicine, all that had a big jump forward. But what type of data would it have been great if that we could have been collecting early on? What gaps were identified early?
I know one, but
yeah, I think public health immediately started to suffer from the struggles of interoperability in order to sort of track and understand how this virus was affecting various communities and how it was traveling. I think also providers, you saw many of these testing facilities that were put up in parking lots. The same thing with ultimately vaccination facilities that were put outside of acute care centers, or even in places out here in Los Angeles. They had them in the Dodger Stadium parking lot. The access to information about which patients could potentially be have comorbidities that would have them be more susceptible to the virus's more difficult effects. That information wasn't immediately available. I remember a picture of a public health organization in Austin, Texas, and they were actually coding in pieces of faxed paper to put into their system to gather information about the virus and testing and all of those kinds of things. And this poor person had a stack of paper about yay high that was up to 10 days old that they were trying to get into their system so that they could start to get the data necessary to marshal the resources around their response to the pandemic. It was very clear that there was just a lack of the ability to share information that put us at a disadvantage.
Yeah, and actually we're with a group that wrote a paper on this actually. Another thing was, even if you were digital, when you do things that seem like they're good as kind of shortcuts to accelerate moving, for example, testing, strange things happen when you skip certain steps. Like the first step that was skipped, this is before vaccine, when it was just contact tracing and figure out who to isolate. When the government or local municipalities was paying for the tests and it wasn't being billed to anyone, you tend not to absorb and collect all the demographics necessary to contact the person because you don't care. Guess when we care about your address? When we're trying to figure out where to send the copay you forgot to pay, right? That's who cares. And so when they get the lab tests and all they do is write down your name and your birth date, literally public health departments were getting a person's name, a birth date, and no idea how to contact them, right? I have a positive in front of me, forget contact tracing. My first contact has to be the person that is positive to figure out where to go next. I don't have their phone number. I think I know what city they're in because I know the test was done. So it was an interesting exercise. A lot of the HIEs were trying to help with that, with matching partial information to expected addresses to get in touch with people. And in a disease like this, where you need to isolate quickly, especially pre-vaccine, and before we have herd immunity with good vaccination numbers, you need to isolate and not infect more people. That's hours, not days. And you saw that, I saw that pile too in Texas. That was weeks. They're already, if they had COVID and were a well person, they're probably fine already. Who knows what damage they caused in the community by the time we find them. So we need to, we need to think about the full interoperability trip and say, maybe having that little, maybe it's very convenient just to have that little small thing where all I got to type is a medical record number and a birth date and a last name. That's great to get the test done, but spending another 15 seconds would have made the next steps a lot easier when we got to the things we really wanted to do when it turns out someone was positive or negative and what to do with it. So we were missing a bunch of data. It was actually very hard in the beginning, and it actually still hasn't been fixed that well.
Well, and we have to remember as our move forward, looking at long-term, what's next as we move into boosters and other things in the future and other changes for variants, that our initial data may not have all been complete. So we've got, how's that going to impact moving forward too?
That was one of the, for years and years, as I worked with vendors who went through certification, and they would certify criteria around public health, immunization and syndromic surveillance. And they'd always say, well, what's the importance of that? Maybe it's good to report it to your local health department or something. And we'd always say, well, if there's ever a bad viral pandemic, we'll be able to gather the data and rush resources. And just like what you're saying is, we were weeks and weeks, we were flying blind, weeks behind, everything. There was a gap there. That was a giant gap. And something else that you touched on a little bit there, Paul, has to do with interoperability is we don't really have a universal patient identifier. That's a challenge that would probably help interoperability. So I guess there's some workarounds that are being done to try to identify who somebody really is uniquely. What do you think?
Yeah, interestingly, there are two concepts that converge and regularly get confused. And just like Lesley, I saw a couple of the chat things. I couldn't help myself.
Yeah.
And this patient access thing is bringing this up. There's identifying you are who you say you are, right? And that's the focus of identity proofing and the IL2 NIST level this, and okay, that's fine. That just confirms that the person at the computer is very, very, very likely to be the person that they're representing themselves to be. Okay, great. The next step of whether the record I'm holding in front of me is the same person as the other person across the computer is done by demographic matching and algorithms that try and take that data, that enter data from that proofing, and determine if the data I have is sufficient enough to confirm that that's the same person. And I think there's this nirvana of we get to a high level identity proofing and interop gets better. I just fundamentally disagree. All it does is create the legal impetus to say the person on the other side is who they say they are, and they have the right to their data. But finding their data based upon that information isn't necessarily going to work so well if I don't trust the data I have locally. If you think about it, and I don't want to insult anybody that's on the phone, but the reality is that like the second lowest paid person in the hospital is the person entering all this demographic data, right? It's at the front desk, it's registrar, it's not very high on the totem pole in terms of pay, education, everything. But they're doing probably the most important first step is make sure you have the demographics right, that it addresses type properly, that the birth date is correct, that all the identifiers are there to do this matching because we don't have that universal identifier to rely upon. So it's amazing. All this interop work is dependent upon that first step of nowhere near a clinical grade person and what we're doing every day. So it's amazing to me. We have no standard for that. That's the part that in all the information blocking and TEFCA, you'll see my comments on, We do not have a minimum standard for how to match across two things. Everybody makes up their own guess on that, on what they think is good enough to reveal their data to someone else. I think that's unfair to patients more than it's unfair to providers, quite frankly.
We're getting near the end of 2021. And so in terms of interoperability and next year, what things are we on the cusp of that's going to be advantageous to interoperability you think we may see over this next year?
Well, I'm still sure waiting and hoping even before next year that we're going to see the ONC FHIR roadmap and start to see where or how the current TEFCA plans and FHIR will come together. That's the one I'm waiting for.
Yeah, we're CommonWell is obviously not, we're actually working on FHIR internally. We're in a slightly different camp. We'd like to see TEFCA launch as it's defined now before we start talking about the FHIR roadmap, because I feel like there's a distraction problem. The TEFCA structure as it is today, and it's not really in your 9 boxes here, is a major thing. It's a major thing right now. The big discussion on, is it going to work, right? Trusted exchange framework and common agreement. We can get a common agreement. Who's going to sign it doesn't make any sense. And there's some weirdness in there right now that some people know more than others because they're in certain work groups. That we hope it does what it was intended to do, because I mentioned the patient matching thing. That's still very gray. Actually, I'd say it's opaque. Like, it's hard to figure out what we're really supposed to do there. And we're a network that's based upon doing patient matching across entities. So we actually probably doing this okay, but when we leave our edge, what happens next? What happens when we go to the next HIE? And they might be doing it very well for their region, but we don't know how they're doing it. They don't know how we're doing it. So how do we release the IP and the intellectual property and have a conversation about how do we all want to do this collectively? Because doing it by our own little silos isn't going to make the ball move. Then you lay FHIR on top of it. FHIR itself is a data transport and data kind of a codification thing, but it doesn't change that fundamental problem of how to go find the data. So we need both to go and to get it all to work.
Just with one other point of clarification. I'm sorry, John, I'm sure you want to jump in there too. One of the things that Jim started with was talking about barriers and things that had been identified with respect to interoperability. And of course, a lot of the ONC FAST work has provided us wonderful recommendations. And one of the barriers is having problems knowing that we can be scalable, especially when we talk about authentication and authorization going along with that. And then, of course, layered onto using FHIR. So definitely, I think some of the best practices that are being discussed, the recommendations, for example, using the unified data access profiles, et cetera, as a mechanism to allow those extra embodied credentials to move along with the messages. Those things are going to be huge for everybody to look at and continue to explore. But I do agree with you as well. I know camps are all over on the TEFCA as it stands now, or TEFCA with FHIR, and do we wait or do we push? I agree with you. Whatever we do, it needs to be well communicated, well coordinated, and allow for everybody as they are ready to move forward and bring everybody along. So certainly from there. Sorry, Jim, go ahead.
And just building on what both Lesley and Paul were saying, trust and being able to authenticate are huge. I think we can have the most sophisticated technologies in the world to be able to facilitate the secure communication. It's just a matter of understanding who we're communicating with. Can they be trusted? And also ensuring, to Paul's point, the ability for us to absolutely identify a patient so we know we're talking about the same person and not a different person. These are very difficult problems to solve in a society that values privacy and has to kind of balance the need for being able to put as much information as possible, accurate information as possible, at the point of care in the physician's hands or the provider's hands, and at the same time understanding that in order to do that, there are situations where privacy may prevent you from being as accurate as you want to be.
Well, thank you for that. We only have about 4 or 5 more minutes, and there's one more topic I want to touch base on here. In terms of interoperability, we know the types of data and information that historically have gone into EHRs or paper charts or whatever. But with the pandemic, we start getting data coming in from telehealth applications. There's a giant move. I think it's going to be more than a move. It's going to be a wave of remote patient monitoring where data is coming in from devices in a patient's home. And there's also patient reported data.
Mhm.
And so that's new, where data other than from a lab or a provider is entering into the system. Can that data be trusted? Will it be siloed, and identified as different validity, valid data? Where's that going to go? That's going to be dealt with, obviously. Looks like you're going to give me something on that, Paul.
Well, I'm thinking because I've always had some issue with the patient-entered data being untrusted.
I do too, sure.
Yeah, I find that an engaged patient is probably entering more accurate data than my providers are. Like if I'm going through the effort of tracking this stuff, and I might not have the right device. Like I may have a blood pressure monitor at home that's not properly calibrated, isn't giving the right data. I get that. But if I'm taking over-the-counter medicines and tracking that and going through all the effort, the likelihood is that is my stuff. That is what I'm taking. And it might be important to know that I decide to, take over-the-counter things now that used to be prescription only, right? That can contraindicate with things. There are a lot of dangerous over-the-counter drugs that we don't realize are dangerous until someone doesn't know that you're taking it and you're having something injected into you in the ED. And they go, oh crap, I didn't know that you were blah, 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 blah. So get it all in there. It's provenance, right? Just add that it was entered by the patient. Who entered this? It wasn't Cleveland Clinic. It wasn't Yale. It was Paul Wilder. And when I'm cognizant, you can ask me, but while I'm in the ED and I type something in there that I'm probably taking all the time, for now, I would trust it until I wake up, right? I think it's time to get over that. What we're really concerned about, though, is the new data types that have no relevance or understanding in clinical circles at all that we don't know what to do with. Is it important to know how often I run, or that I run an 857 mile versus a 920? It's probably just good to know that I exercise in general, and that's more than 3 times a week, and that's probably good enough. And the rest of the data is noise into my GPS and my tracking of where I went and what marathon I was doing. But I think we should start embracing that extra data, because it's going to get more and more important as healthcare gets strapped and we have less nurses and doctors available. We have to do things ourselves.
There are definitely new avenues. Before we totally run out of time, I want to give each one of you 30 or 45 seconds to wind things down. How far are we along the trajectory of interoperability, and are we on the right path with it? John, I'll start with you, sir.
I think that as long as we're fighting for all of the various components of it, still on the upswing of the arc. I think we've got a ways to go. And there is certainly a lot of information and a lot of regulation left in our future. So I do think the journey is going to continue. I think starting to use the tools that are emerging in technology, and rather than forcing interoperability into the round hole that technology allows, but rather that think about using technology to allow us to put whatever kind of peg we want and have that be the translation layer is going to be the biggest piece of that'll be a game changer here.
Okay. Lesley, are we still on the upswing?
Oh, absolutely. I'm with John there. I think we're looking at decades of implementation before we can really feel comfortable as a patient going from one place to another and having a longitudinal record. But definitely everything that's been said, I totally agree with. And also we just want to reiterate that the importance of all stakeholders and having trust with each other through the process and moving this data around is going to be absolutely huge. and making sure that everybody raises the bar from a privacy and security perspective as well is just of utmost importance to the success of this.
Paul, where are we on the football field? Are we about to cross the finish line? Or are we at the 50-yard line? Where are we?
We might still be at the kickoff. I'm not sure if I get
Okay.
there being offense yet.
Yeah.
No, I mean, things are still growing exponentially. CommonWell Exchange is about 25 million documents a week. So that's about $1 billion a year.
Sure.
It took us 7 years effectively to get to our first billion documents. And now our run rate, if we stay at our current level with no growth, is as much every year as we've done for the 7 years prior to that. And what's interesting there is not the numbers and chest thumping, is that every time I think the curve is going to start leveling off, it doesn't. It still keeps going up, indicating there's still a lot more growth. And you will find a lot of practices connected to CommonWell, because we have the data, that still have never touched a single document over the network, right? They're still looking for the reason to click that extra button.
Exactly.
And, even if there's only a couple thousand, it's really only a couple thousand out of 25,000, still indicates there's a fair amount of work to do to make it part of the workflow, because that means that the application isn't doing automatically, nor is the person first pressing the button either, right? There's no reason to go get that data. And we're seeing more and more reasons. I expect those numbers to be adding zeros over the next couple of years. And then we're going to throw FHIR on, and it's going to be even more berserk because it's going to be discrete data with transactions happening all the time. So no, we're still early parts of this game.
Okay. Well, Carol, we're going to send the football over to your side of the field.
I'm a big football fan, Jim, so I appreciate that. I want to thank you, of course, for moderating today's event, and to our terrific lineup of panelists, Lesley, John, and Paul. I'm putting it out there right now that you must come back for our annual event next year and make that happen. We'll, of course, be back in 2022 with our series of virtual roundtables. Until then, have a happy and very healthy holiday season. Thank you all.